to turn off their microphones so that there's no interruptions. And there will be a question and answer period at the end. So please save your questions. And then when prompted, we can have everyone turn on their microphones, and I'm happy to take questions.
Okay. Good luck to you, Mike.
Thank you so much.
Go for it. You're welcome.
All right. If it's all right with everyone, I'm going to go ahead and start now. It looks like we're at about 8 o'clock. All right. So, okay. Hello, everyone. My name is Michael Barnett, and I am presenting today on a project entitled Increasing Chlamydia Screening in the High-Risk Population Using Electronic Notification and Targeted Education, a Primary Care Approach. My team includes Chris Balkasoon and Jody Santu. Chris is a DNP and adjunct professor at USF. He's also my mentor in clinical practice and was boots on the ground supporting me on site through development, implementation, and evaluation at Native American Health Center. Jody is also a DNP and is the director of clinical training at USF. She was instrumental in helping me with research, analysis, and documentation for this project. I am lucky to have such a great team, and I want to thank you both for your support on this project. So thank you. Okay. Let us begin with a little background on the problem. Chlamydia is a sexually transmitted infection that is very common in the United States. In 2018, there were 1.8 million reported cases, which represents a 14% increase over 2014. For comparison purposes, 1.8 million people is more than the total populations of Montana and Alaska combined. While 1.8 million is the number of reported cases, we don't know the actual prevalence of the disease because the majority of symptoms have no symptoms. Therefore, most people don't know they have it. I've read, noted on a CDC website, that the number is estimated to be about 7 in 10 people with the infection have no symptoms at all. This infection is easy to treat with antibiotics, specifically a one-time dose of azithromycin. But if people don't know they have it, they simply won't seek treatment. Finally, leaving this infection untreated in the body allows it to spread and can result in significant reproductive problems later down the road, especially for women, including pelvic inflammatory disease, chronic pelvic pain, infertility, as well as life-threatening ectopic pregnancies. The United States Preventative Services Task Force is an independent group of national experts who research and develop recommendations for clinical preventative services. In 2014, they published recommendations calling for the annual screening of all sexually active females aged 24 and younger. Recommendations are based on research as well as data from reported cases, as illustrated in the graph, showing that females aged 15 to 24 represent the highest risk category. Several other organizations have followed suit, publishing similar guidelines, including the Centers for Disease Control and Prevention, American Academy of Family Physicians, American College of Obstetricians and Gynecologists, as well as the American Academy of Pediatrics. Primary care is the optimal place to screen for infection. According to the American Academy of Family Physicians, the primary care provides health promotion, disease prevention, health maintenance, counseling, education, as well as the diagnosis and treatment of acute and chronic illnesses. That's a lot of things to do. Screening is easy and requires only a urine sample or a vaginal swab that can be self-administered by the patient. However, while primary care is the best and most optimal place to conduct screening, it's not without challenges. Primary care appointments are typically 15 minutes in duration and usually include the management of a chronic condition and/or the addressing of a new complaint. We can see the effects of this challenge by looking at insurance data, which shows that for commercial health insurances like Kaiser and Aetna, screening rates on this high-risk population are 47%, while for Medicare and Medicaid patients, the rates are slightly better at 55%. The setting for this project is the Native American Health Center, the NAHC, which is a federally qualified health center in Oakland, California. An FQHC is a community-based organization that provides comprehensive primary and preventative care, including health, oral, and mental health, as well as substance abuse services to all people, regardless of health insurance status or ability to pay. The FQHC is considered a critical component of the healthcare safety net and functions to provide services to underserved populations. NAHC is a primary care outpatient community clinic that serves a diverse urban population. This population consists of approximately 21% Native Americans, 20% African Americans, 47% Latino, 12% European Americans, 9% Asian Pacific Islanders, and 1% unknown. The languages spoken at the clinic include English, Spanish, Hmong, Chinese, and Tongan. A needs assessment was performed at NAHC in early of 2019, with chlamydia screening rates being evaluated for the prior year of 2018 to 2019. At that time, we found rates of screening in this high-risk population were at 14%, which is significantly lower than the national average. The aim of this project is to improve screening rates for chlamydia infection within a primary care setting by using an electronic notification system and targeted education to benefit the high-risk patient population of sexually active females aged 24 years old and younger. Phrased as a PICO question, we might then ask, for sexually active females aged 24 and younger, does the use of an electronic notification system with targeted education improve screening rates for chlamydia as opposed to the standard care model over a 1-year period? In order to learn more about how to improve screening rates, I went to the research. As Werner von Braun noted, research is what I'm doing when I don't know what I'm doing. Von Braun was a German-American physicist and rocket engineer whose team launched the first U.S. satellite into space, so I think he's a pretty smart guy. Utilizing the research databases PubMed, CINAHL Complete, and Scopus, I searched for articles using the keywords chlamydia, screening, and primary care. I established limitations to include only recent research within the past 10 years, being from a peer-reviewed journal, having been written in English, and being based on the highest level of evidence, including systematic reviews, randomized control trials, and meta-analyses. I came up with 47 initial research articles and then filtered these results by excluding articles that were based on alternative topics like retesting after treatment, partner notification, the development of screening protocols, opportunistic testing, testing at home or in the emergency department, and articles that focused on men and transgenders. I apologize for the busy slide here, but it's important as it summarizes 3 of the studies for which this project is based on. Guy et al. In 2011 conducted a systematic review that evaluated interventions to increase chlamydia screening within the primary care setting. Of the interventions reviewed, they found 6 that had statistically significant increases to screening rates. These included, number 1, collecting urine samples from all female patients at the time of registration. 2, linking screening to pap smears. 3, the use of electronic notification systems. 4, education and workshops for clinic staff. 5, internet-based continuing medical education for providers. And 6, offering free sexual health consultations for patients. We incorporated recommendations for an electronic notification reminder as well as educational material for providers and staff as a way to improve screening. Next, Keegan, Bledrich, and Pelpert in 2014 conducted a comprehensive systematic review that evaluated screening recommendations, test methods, barriers to screening, and the management of infection. Barriers to screening for providers included a lack of knowledge, being a male provider, and working in a rural setting. For patients, barriers included not knowing that chlamydia infection can have no symptoms, the fear of receiving a positive diagnosis, and the stigma associated with the topic of sexually transmitted infection. Furthermore, it added that patients who were of minority race and ethnicity, who had low socioeconomic status, and those who lacked health insurance generally had lower screening rates than others. This really hit home for us at Native American, as we serve a minority population of lower socioeconomic status and targeted for those who lack health insurance. To improve screening, this study concluded that for providers, a combination of education and financial incentive would be most effective. For patients, it concluded that offering a mail-back sampling kit, allowing for testing to be done at home, as well as offering tests via urine or vaginal swab, which is less invasive and painful, would be the most effective methods. What we took away from this research is the importance of education to address the lack of knowledge for providers as a method for improving screening, while also validating that our method of testing, which is a urine collection, was supported by evidence and conducive to our goal. McDonough et al. 2018 conducted a systematic review to identify barriers and facilitators for patients and providers with regards to screening in the primary care setting. For patients, it found that barriers include the lack of education, knowledge, awareness, their beliefs about the risks, embarrassment, the fear of receiving a positive result, and stigma. For providers, it identified barriers including the lack of knowledge and awareness, forgetfulness, lack of time, lack of testing guidance, and concerns for the effects on the doctor and patient relationship. Facilitators provide support to people in order to achieve beneficial change. For patients, facilitators included increasing their knowledge and awareness, emphasizing the belief that testing is a responsible, mature, and healthy thing to do, worries about an asymptomatic infection, and the easy, inexpensive availability of testing. For providers, facilitators included training, increasing knowledge and awareness, increasing confidence, the use of prompts and reminders, and rewards and incentive programs, promotional material, and organizational testing policy. For our project, we addressed the lack of education as well as recommendation for improving knowledge and awareness. The electronic notification reminder also served to help address forgetfulness in the setting of a lack of time and to support the recommendation of prompts and reminders. This project is designed to enhance screening rates for chlamydia, which touches on several ethical topics. Autonomy is an important ethical consideration since patients maintain the right to choose whether or not they are screened for infection. And while this is in fact a limitation of the project, it's still very important to recognize and support the patient's choice as to what happens to them. Beneficence is the act of providing benefit or doing good for the patient. This ethical topic is the basis for this project, as identifying and treating infection early leads to benefit of overall health and wellness of the patient as well as the community. Non-maleficence is to do no harm, and this is pertinent when considering potential risks patients have for physical, psychological, social, and emotional harm that can occur when screening for sexually transmitted diseases. Veracity addresses honesty and truthfulness in communication, and this principle ties into screening with regards to comprehensive, accurate, and objective sharing of information, as well as ensuring the patient's understanding of that information. This translates to informing the patient of recommendations for screening, making them aware of risks and benefits, and making time to answer all questions honestly and based on current evidence. Project framework is a vital part of a successful project. Research by Jones and Van de Van found that resistance to change within an organization has an increasingly negative relationship over time. So the framework for my project is based on Cotter's change management model. Advanced practice nurses in today's healthcare system are in a challenging position trying to promote positive outcomes for their organization while constantly leading change in order to do so. This model is novel in that it is based on a dynamic, non-linear, 8-step approach to implementing change. These 8 steps are illustrated here on the PowerPoint slide. We chose this model to address anticipated team resistance to change and to facilitate successful implementation of our project. As an example, generating short-term wins can serve to turn concerns, negative feelings, and resistance to change into positive feelings, such as optimism, urgency, reality-based pride, excitement, hope, and enthusiasm. So just like in this episode of How I Met Your Mother, every big problem needs an intervention. The intervention for this project leveraged research showing that a multifaceted approach, including the use of an electronic notification system and targeted education for providers, can be effective to increase screening rates. Previously, NAHC functioned with an older electronic medical record system by the name of Cerner, which did not include provisions for notifications or reminders. The organization upgraded to Epic in May of 2019, and provisions were included to allow for configurable notification reminders. So we established during integration that all female patients between the ages of 13 and 24 have annual reminders to conduct chlamydia screening such that Epic flags providers and staff when opening the patient's chart. The current standard was no electronic notification, which left providers tasked with recalling or manually looking up if the patient was due for screening and what screening needed to be done. In the setting of numerous screening recommendations for different populations, this can be very challenging as well as time-consuming. The targeted education model was created using a PowerPoint format and developed to share current knowledge as well as promote confidence and reinforce understanding of the different aspects of chlamydia care. Objectives for the education included that by the end of the module, participants would be able to describe what chlamydia infection is, what are the symptoms, including the most common symptom, how to identify the highest risk population, describe guidelines for screening and testing, explain how treatment is provided, and identify special considerations of care, which basically is the testing and treatment for partners. The survey was conducted using Qualtrics and provided through an email link, which consisted of 7 questions with a Likert scale being used to quantify the data. The response value of 1 represented a strong positive response, and 5 represented a strong negative response. So basically, data with a value close to 1 equates to more confidence and knowledge, while a value closer to 5 reflects lower confidence and knowledge. There were no upfront costs for implementing this project. Secondary costs included time for developing educational material, surveys, and project oversight. At a rate of $60 per hour, which is a typical clinician rate, and an estimated time of 16 hours for development, total secondary costs are estimated to be $960. Further estimating 30 minutes for staff to complete the education module and survey, with physicians at $60 an hour and medical assistants at $30 an hour. The total time for education and survey is $5,400 for a total project cost estimated to be $6,360. Establishing a cost-benefit analysis is challenging and relies on a combination of data and estimates, given that the majority of infections are asymptomatic. It is estimated that 10% of women who have chlamydia left untreated will develop into pelvic inflammatory disease. Research conducted 10 years ago found that the cost of treating 1 case of pelvic inflammatory disease was about $2,000, and that number is not adjusted for inflation or increases in healthcare costs. Finally, data shows that in 2018, there were 1.8 million cases of reported chlamydia, with estimates of 2.86 million total infections for the year. Assuming that 50% of this 2.86 million is female, this would result in 1.43 million infections. With a 10% risk for pelvic inflammatory disease, the math results in 143,000 cases. Costing just shy of $2,000 each, results in an estimated net cost for failing to screen for chlamydia at $285 million annually. I'd like to note this is a nationwide number and only looks at the complications of pelvic inflammatory disease. A SWOT analysis is a useful tool to assess the strengths, weaknesses, opportunities, and threats of a project. We can leverage certain aspects of the project to enhance results, while also reducing the chances of failure by understanding what is lacking in order to identify and mitigate hazards. For this project, strengths included an ease of implementation, since the organization was planning a migration to Epic, and the project only required stakeholder buy-in for the notification system to be configured and activated. Additional factors include the leveraging and use of technology in order to improve efficiency in a primary care setting, as well as the clinical staff, which has a good amount of experience with low attrition rate, and this consistency and established teamwork can serve to strengthen the success of the project. Weaknesses of the project include the additional time required after notification to place orders and discuss screening with patients, which can be challenging when great efforts are already put forth to avoid running behind on appointment appointment schedules. Additional weaknesses include notification overload, which may initially occur if many notifications were activated during Epic rollout, as well as the possibility of corporate policy, which can serve to limit adaptability and resist change within a quickly changing environment. Opportunities arise from the increasing education, awareness, and dissemination of knowledge regarding chlamydia testing, screening, and treatment. Additional opportunities include business development, should the organization choose to implement this project into additional clinics, as well as the possibility of modifying the project bundle for other screening needs, such as depression, smoking, obesity, HIV, etc. The most substantial threat to the project comes from the COVID-19 pandemic, which has resulted in the increased use of telehealth visits and may negatively affect the ability to screen high-risk populations. Additional threats come from social and cultural influences in the community, as patients may see screening for sexually transmitted infection as taboo, be uncomfortable discussing with family or partners, and may avoid the matter altogether. Finally, it's important to note a changing political and economic landscape. And while this has become less of a threat with the current presidency, reversing changes made to Obamacare remain to be seen. Outcome measures will include the screening rates for females aged 13 to 24, measured from May 2019 to May 2020. That rate will then be compared with screening rates for the same population measured on the prior year from May 2018 to May 2019. Additional outcome measures will include an assessment of the effectiveness of the targeted education. This will evaluate provider knowledge, comfort, and ease with enacting chlamydia screening. A pre-education survey will be provided through email assessing provider and support staff knowledge of chlamydia care and comfort with discussing the topic with patients. A targeted education module will then be provided to staff. A post-education survey will follow the education module, again assessing provider and support staff comfort in these same areas and using the same questions. Answers for the pre- and post-education survey will be assessed and compared to gauge changes in provider knowledge and comfort regarding chlamydia screening. As mentioned earlier, screening rates for the year 2019 demonstrated a screening rate of 14%, which equated to 40 patients out of a total of 285 high-risk patients that year. This is the pre-intervention or baseline data. For the year 2020, screening rates were found to be 50%, which equates to 156 out of 312 patients. This is the post-intervention data and represents a whopping 256% increase in screening over the prior year. Education survey data included a pre- and post survey based on 7 questions using a Likert scale and was used to assess the targeted educational component of the intervention. 12 staff members completed the pre-survey, with 6 staff members completing the post-survey. Mean pre-survey score was 1.76, while the mean post-survey score was 1.64. This represents a small overall improvement, while both scores still came somewhere between very comfortable and somewhat comfortable, that being a 1 and a 2. Perhaps the greatest single barrier for this project came from the COVID-19 pandemic, which affected everyone and evolved into a California shelter-in-place order that happened on March 16, 2020, and impacted the project through its completion on May 31st, 2020. This resulted in no patients coming into the clinic between March 16th and May 31st. As telehealth appointments were instituted shortly afterwards, it's unclear how this impacted the ability for providers to screen their patients. Also, as a result of the pandemic, the targeted education module had to be modified from an in-person education to an email for providers and staff to read as time allowed. This provided no opportunity for in-house teaching, the reinforcing of information, or questions and answers. The results of the survey demonstrate lower than expected results and suggest this method of education is not the ideal or most effective method for staff education and raising awareness. Additional barriers for this project include the patient's right to autonomy, which translates into their choice to not screen for really any reason at all. Many reasons are logical and might include concepts such as virginity or celibacy. However, many reasons may not be logical and include the fear of a positive result, their desire to minimize risky behavior, or stigma. Despite fear being perhaps an illogical reason to avoid screening, the potential risk of losing a partner or even becoming subjected to intimate partner violence is very real. For providers, barriers include time restraints in the setting of appointments that typically run 15 minutes and resulting in a lack of time to inquire, educate, and answer questions about chlamydia screening. This project mostly benefits the high-risk population of females aged 13 to 24 living in an underserved area by helping them avoid costly and painful lifelong reproductive comorbidity and to live healthier and happier lives. Providers within NAHC also benefit from this project as they are without doubt committed to providing as high a quality of care as they are capable of, and this project helps them to better achieve their goal. This project also benefits the organization, as electronic notification can be configured beyond chlamydia screening and can incorporate any number of identified and evolving screening criteria, including obesity, depression, smoking, and cancer, to name a few. The most important lesson learned was that the use of technology, specifically electronic reminders, can be very effective in a busy primary care setting. Results of this project demonstrate that the use of an electronic notification system resulted in a significant increase to screening rates, independent of supportive activities such as education, surveys, or raising awareness, and was a primary contributor to the change seen in this project. This project began through a needs assessment where data on the rates of communicable diseases were assessed against guidelines and national averages. Thus, another lesson learned is that routinely assessing organizational outcomes can help to identify gaps in care and reveal opportunities for advanced practice nursing to improve patient outcomes. Providing an educational component for staff members, including chlamydia knowledge, screening guidelines, and treatment modalities, has been recommended in literature and can be beneficial for raising awareness and keeping staff updated of potentially evolving changes in the standards of practice. While the impact of this part of the project was lower than anticipated, a lesson learned here is that the impact of education may depend on the format and environment with which it's completed. Screening for chlamydia is an effective method to reduce comorbidity in the community, but there are a number of challenges to doing so in a busy primary care setting. Currently, the national average for screening for this infection is approximately 50%, but a needs assessment at a local FQHC serving underserved populations found that rate to be 14%. By implementing a bundle that includes electronic notification system with targeted education, screening rates for this high-risk population were showed to increase to 50%, which brings this clinic in line with the national average. And so here are my references. And a few more. And a few more. Maybe a couple more. And I think this might be the last one. Okay. So now I've wrapped up my presentation, and it's a great time to ask questions if you have them.
Michael, great job. Excellent job. Very interesting. You know, I'm glad to see that your population was focused on 24 or younger. I know that working in an urgent care setting.
So that we can't hear anymore, I think.
Really?
No, I can hear her.
Oh, you can? Okay.
Yeah.
Oh, Jody can't hear me. Oh, anyways, I know from working in at urgent care and a school-based health center that the chlamydia is so prevalent among that age. So I think it's awesome that you took this on as a project, and you know, great job and congratulations to you.
Thank you so much.
Hi, Mike. I'm Francine Serafin-Dixon. I do not teach in the NP program. I teach in the PHL DNP program. And I listen to all of these NP presentations because I learn a lot from them.
Good.
And I learned so much from you. And I want to point out two things. Your presentation was stellar. You just covered everything in such a clear, engaging manner.
Thank you.
Slides and everything. And I also really appreciated how you took a slant from Cotter that was a little more personal and incorporated kind of the emotional aspect of it. And so many times we don't when we use frameworks, and we need to because we're working with people. So great job.
Thank you so much.
Hey, Mike. It's Chris. How you doing?
Hey, Chris.
Hey, great presentation.
Thank you so much. I'm glad you made it.
Yeah, thanks.
Are you at work?
I am.
Okay.
So basically, yeah, you summarized the exact. You summarized the data very, very well at the clinic, and I think that especially that transition from the previous medical record system to Epic really was able to allow us to gather the data that we needed to show the effective rates of screening rates of chlamydia. So I was really impressed that you were able to put that so clearly. It was so, as we remember gathering the data, it was a lot of parts that we had to put together, and you put it together perfectly. So I'm really proud of your presentation. It's excellent. It's a very, very well written presentation. So good work to you.
Thank you so much, and thank you for your help.
My pleasure.
Yeah, awesome. Welcome, Chris. Welcome, Dr. Serafin-Dixon, as you joined. And congratulations, Mike. You know how proud I am of you, and the results of your project speak for itself. So, a lot of hard work, collaboration, leadership, concepts you didn't know you had in you. You pulled it all together, and it's been so fun watching you grow and take this DNP journey. You know, we started here, look where we've ended up. I am so very proud of you and your accomplishments. And I know Chris feels the same way, you know, from where we started to where we are. So I don't have any questions. I want to thank you for doing all the hard work. You are truly the demonstration of what I would call the DNP student who demonstrates the leadership, has gone through this process very, very successfully. And I know you're taking a lot with you, both in your NP role and your doctoral role here. We've got a long ways to go, a lot done, but remember, this is a part of your journey, all these tools that, you know, will manifest in your life here on out in healthcare. So with that said, I want to honor and congratulate your work, welcome you to our DNP family, and congratulations, Dr. Michael Barnett. You've successfully completed your journey.
Thank you. Thank you so much.
Yeah.
And a big thank you to Paras for all the support. I know you've been there alongside the entire time. Chris, thank you so much as well for being a part of this journey and opening up the environment to allow, Mike to come in, work with you, and make this happen.
My pleasure.
Thank you, everyone, for your support with him. We appreciate you.
Very much. Thank you all so much for your support. It has been a challenging but extremely rewarding journey, and I'm very thankful to have been able to go on through it.
You did it. You did it, Mike.
Congratulations to you. Time to celebrate, right?
Absolutely.
All right, Dr. Barnett. Dr. Congratulations to you.
I love it.
This is the moment. This is what it's all worth, Mike. All that pain, all growing, all those sighs and heavy breaths. And am I gonna make it? Am I gonna do this? Should I go? Yes.
I'm gonna make it. I'm gonna make it.
Yes, you are. So yes, congratulations.
Thank you.
Good, awesome.
All right.
So go celebrate. Have a wonderful day, Mike, and congratulations to you. Congratulations to everyone, all of us, for having you as one of our students and now alums. And go celebrate. Go have some fun, and I'll talk to you later.
Yeah, and I'd like to again thank you and Chris for your support, and I'd like to thank everybody who took the time to log on to listen to me do my presentation today. I really appreciate your support and participation. Thank you.
Yes. Thank you, Emily. Thank you, Francine. Thank you, Trinette, for joining us too.
Thank you. Have a great day.
Thank you. You too.
Thank you. Having a great day, guys.
All right. Bye-bye.